Hi, good afternoon, everyone. I am Dr. Jesus Fernando Inchong, and I'll be your moderator for this afternoon. We'd like to welcome everyone to this webinar entitled Challenges, Solutions, and Innovations in Surgical Training During the Pandemic and Beyond. For those who just tuned in, this webinar is brought to you by the Philippine College of Surgeons Committee on Surgical Training and is the third and the last of the series. Last week, we discussed the COVID-19 pandemic implications for medical students, undergraduates, and surgical residency applicants. So how do we choose? Today, we will continue the series by discussing how to conduct virtual examinations. So we will start first in this webinar by honoring God, our country, and our institution. Will everybody please rise for the invocation, followed by the Philippine National Anthem and the PCS hymn.
Lord of wisdom, source of intelligence, we welcome you to this auspicious gathering, an august moment for the pursuit of knowledge that is offered for the glory of your name. We do not wish to ask you more than just you joining us today, but we look forward to your heavenly grace, to amplify the desire for truth, to look up for and become prudent to learning. Keep us grounded in your love and mercy, as we traverse a challenging path to keeping the inclination of understanding you and your most awe-inspiring creation. Be with us, O Lord, and descend your Spirit on us, to maintain an earnest desire for knowledge, truth, and understanding you, the guide of the wise, the stronghold of the learned. This we ask through Christ, our Lord. Amen. Through Christ, our Lord. Amen.
Mga kababayan, ang pambansang awit ng Pilipinas.
Kayang mag-ibig, pero sa silanganan, alam ng puso, sa titik mo'y buhay. Lupang hinirang, kuyak ka ng magiting, sa manlulupin, di ka pasisingil, sa nagtatapulog sa simoy at sa langit mong pagaw, ay ginagam tulad awit sa pagkayang minamahal. Ang isang ng matawad mo'y tagumpay na nag-iindig, ang bituin at araw niya kailan ang may di magtitingin. Lumang ang araw ng walhagin pagsinta, buhay langit sa piling mo. Aming higaya na pagkay mga api, ang mamatay ng dahil sa'yo. to serve without regard of color, creed, or station. We shall seek to broaden knowledge, each discovery will share as a tribute to their life and for the good of all mankind. Let us dedicate ourselves to life as surgeons of the land. We are fellows of PCS, we've a pledge on which we stand to give our talent, time, and skill, to give a helping hand. We'll strive to serve without regard of color, creed, or station. We shall seek to broaden knowledge, each discovery will share as a tribute to their life and for the good of all mankind. Let us dedicate ourselves to life as surgeons of the land.
Again, good afternoon, everyone. I am Dr. Jesus Fernando B. Inchong, and I will be your moderator for this afternoon. Welcome to Challenges, Solutions, and Innovations in Surgical Training during the pandemic and beyond. For those of you who just tuned in, this is being brought to you by the PCS Committee on Surgical Training, and this is actually the third of a series of webinars, and this will be the last. Last week, we discussed about choosing your surgical residents and how they will apply. Today, we will continue the series by conducting a short lecture on how to conduct virtual examinations. We have a very distinguished lineup of guest lecturers and speakers and reactors from 3 different subspecialties under the PCS. So this session will be brought to you by the PCS with the following objectives. That's the general objective. Can you, next slide, please? And the specific objectives. So for those of you who are tuned in Zoom, and if you're not available to listen to us in Zoom, you can follow us in FB Live. So just sit back, relax, and lend us your ears for the next couple of hours so we can bring you this wonderful webinar. With me, of course, is the co-moderator for this afternoon and the chair of the Committee on PCS and Surgical Training, Dr. Andrew J. Pusong. Dr. Pusong?
Thank you, Dr. Jeff. We would like to start by reminding everyone of some house rules. So for our house rules, the moderator will control the flow and presentation and discussion. All panelists must keep microphone status on mute when not speaking. Participants are encouraged to ask questions through the Q&A box. Please observe proper decorum and professionalism at all times. So we will hear our guest lecturer followed by a short open forum. During the webinar proper, we will have all the speakers and the reactors first, and the open forum will be at the end of the webinar. So please type your questions, comments, and reactions in the chat box if you are in Zoom, and in the comment section if you are in FB Live. We will go over them during the open forum. Doc Jeff?
Yep, thanks, Doc J. In any activity of the PCS, it will never be complete. So to formally welcome us in this webinar, let us hear from the able president of the PCS, Dr. Antonio Sai.
Good afternoon. I wish to thank all participants from the different surgical specialties for being here today. These past 15 months have been the most unusual for all. Besides the new normal that we have been adjusting into, education has been hit hard by the ensuing lockdown caused by the pandemic. For the past 15 months, medical education has been virtual. Residency training has taken its sidelines as the health facilities and medical efforts were concentrated to the battle against COVID-19 pandemic. Surgical residency training has also had its shares of woes, as residents were deployed to COVID areas. Besides the diverted manpower, case numbers, too, decreased as the nation went into lockdown. The Committee on Surgical Training of the Philippine College of Surgeons has been concerned about the effect of the ongoing pandemic on the training of surgical residents. By bringing the different specialty training programs together, in this series of short webinars, all of us can gain insights on how to approach this educational bump that we must hurdle. We also look into the future. Medical graduates who will be eventually applying for residency in our surgical program have had a very unusual schooling. Learning and engagement with patients was done virtual. There is need to look closer to the issues of the virtual medical student and its implication on surgical residency training. In closing, I ask everyone to do your share in the fight against COVID-19. Let us convince our patients, relatives, and get vaccinated. Let us help the government vaccination roll out. Help the government do vaccination. It is not just for oneself, but also for family, community, and country. Together, let us all stay safe. Mabuhay.
So thank you very much, Dr. Sai, for that very warm welcome. And now to start the ball rolling, allow me to introduce our very special guest speaker. He is presently the director of the Philippine Association of Training Officers in Surgery, and to talk to us about how to conduct virtual examinations, please welcome Dr. Warren Roraldo. Dr. Roraldo, please.
Good afternoon.
Good day. It is my privilege to speak to you today. My name is Dr. Warren Roraldo, a member of the Board of Directors of PATOS. Today, I am assigned to talk about how to conduct a virtual examination. The outline of my presentation will be as follows. I will give some background, talk about some trends in assessment, the process of virtual exam administration, and state the challenges and possible solutions. This pandemic allows us, or should I say forced us, to embrace the role of technology in education and training. We learn to embrace technology in the way we teach or train and the way we assess. It is also a way for us to be resilient and adapt to the changing times. The educational benefit of technology is here to stay beyond the pandemic. In terms of assessment, we can now assess the 3 learning domains with the use of technology: cognitive by written and oral examination, some attitudinal aspects by oral examination, and the psychomotor skills. Speaking about the use of technology in skill assessment, a PCS fellow is now taking her master's in health education, whose thesis is about assessing video recording of actual operations in the context of standard surgical procedures in our country. She has already validated the assessment tool and is now conducting pilot testing in one of the hospitals in Manila. As we all know, Module 1 or 3 workshop of the competency-based curriculum for training officers in surgery deals with the principles of assessment. I mention this because even if the venue of examination is virtual or online, the principle of assessment remains the same. As trainers, when it comes to assessment, we should always have in mind the question, is it valid? Here are the trends in assessment as written in the Practical Guide to Medical Teacher, 5th edition. In terms of validity, evidence is collected to support the interpretation of the assessment result is valid. It means we, creator of examination, should attain validity in all the steps in assessing learning. Another trend, there is recent work indicating that the act of assessment itself creates learning. How? By giving the trainee feedback, informing the trainees of the results and their progress. Assessment now becomes their drive to learn more. Please take note, results of assessment not only inform us about trainees' performance, but also informs us about our teaching practices. The basic steps in assessing learning starts with determining the purpose of assessment. Diagnostic, like the pre-entry exam of residents, formative, exam while on training, and summative at the end of each year level. Next is develop test specification or the test blueprint. The basic concept of the test blueprint is it should be aligned with your learning objectives or outcomes. The trainee must demonstrate through an assessment that they achieve the learning objectives. Test blueprint will ensure construct and content validity. Construct represents the parameters, while content is the total items or numbers representing the contract. Please note, the American Board of Internal Medicine and the American Board of Surgery post their exam content outlines for RITE and certifying exam on their website. Items should follow test construction guidelines of each type of question. And because we need to ask what is required based on the objectives, created questions must be an accurate, precise, or absolute reproduction of what is required in the blueprint. Determine the MPL before administration. Criterion reference is the recommended method, but the norm reference is usually used for diagnostic exam. In test administration, the goal is maintaining integrity. In online assessment, this step possesses the most significant challenge. After the test, do item analysis before the final passing score is set. In a book, Teaching and Learning in Health Science 2010, our very own Dr. Arman Chrysostomos states that item analysis influences the passing score or the determined MPL. But there are more educational benefits of item analysis. It can identify the examinee's strengths and weaknesses and identify faulty items, to name a few. This is how a test blueprint looks like. the construct or parameters to ask, how many items per construct, and what taxonomy of the cognitive domain it represents. In an online examination, the recommendation is that items must represent the higher order thinking skills of the taxonomy. Again, question items must follow the test construction guidelines, and the items accurately represent what is written in a blueprint because the blueprint ensures construct and content validity. For performance tasks, a rubric for scoring is mandatory. The parameters in a written rubric represents the objectives. Caution in using any rubric or assessment tool. Make sure that the tool is validated and pilot tested. Let me focus on administering the test specifically for written examination. In a traditional face-to-face exam, we must ensure the exam question is secure, the venue is conducive and accessible, and the time limit depends on the number of items. In online examination, administration of tests has more challenges. The above concerns are highlighted in a virtual exam. Consider the scenario depicted in the image. What are the possible forms or scenarios to be considered for the act of cheating? Another person taking the exam, another person in the room that may dictate the answer during the exam, able to use another device to communicate with another, access to reading materials, print or online, access the exam beforehand, even access correct answer of the exam, to name a few. Add to this, there are plenty of YouTube videos on how to cheat during online examination. In her talk in a webinar, Trudy Roberts, past AMEE president, took this definition of cheating by Harper, breaking the rules to get ahead. The temptation to cheat is very high, especially for summative assessment in online examination. In virtual examination, there are several considerations before we can administer the test. A detailed written guideline of the conduct of examination is essential. It should answer all the possible queries of the examinee. What examination software to use? Open source software such as Google Forms or examination feature of an learning management system are the more commonly used. Take note, any email address can access the exam in Google Forms if they have the link, while access to the LMS exam can be limited to enrolled users only. To counter this challenge, make sure only the registered email address can take the exam. Once the examinee gets disconnected in Google Forms, the examination will start from the beginning, while in LMS, it will begin at the last item not yet answered. The server capacity is also crucial because this will determine the number of concurrent or simultaneous users the server can accommodate. A dry run is mandatory before an actual exam to test the server. Particular software or platform will require a compatible operating system of the gadget to be used by the examinee. And of course, internet speed. A decent online video conference requires at least 4 Mbps, while taking an examination without video needs 0.5 Mbps. Uploading test questions is easy. You can create your exam in a Word file and upload all the items you made simultaneously. Here are the links on how to upload exam questions in Google Form Quiz and upload exam questions in the quiz feature of a learning management system. After uploading the questions, the next task is determining the exam settings, the exact time the exam can be accessed, and the duration of the exam. In the online exam, the recommended duration is 1 minute per item. On question behavior, we can shuffle the numbered items and shuffle the alternatives. It will result in no two examinee will have the same numbered item and lettered choices. Restrict to only one attempt per examinee. After the exam, the results can be automatically generated, including psychometrics, in an Excel file. The challenge is that the item analysis for both Google Forms and LMS quiz feature is not the same as the item analysis we used to see before using the Scantron software. Do not worry, the Scantron format can be derived manually using the Excel file. The next question is how we will maintain integrity. Existing online learning integrity approaches can be divided broadly into two types: prevention and enforcement. Prevention approaches are proactive strategies that stop misconduct from happening in the first place. Enforcement approaches, on the other hand, are defensive strategies that detect academic misconduct. To discuss further prevention strategies, Jones in 2009 advocates using a honor code and authenticity statement to ensure trainees understand and commit to institutional values of character and integrity. Let us review the evidence of the effectiveness of these strategies and the issues for them. Studies by Schatz 2011, Hart 2009, Kitahara 2007 found weak evidence of examinees' commitment to honor the code. It does not prevent impersonation. The same findings with authenticity statement in a study by Morgan and Mastin 2009. Therefore, we cannot rely on an honesty system alone. For the second part of the integrity approach, let us discuss the defensive strategies geared towards detecting academic misconduct. Number 1, to control a testing environment that prevents students from printing, copying, screen sharing, screen capturing, going to another website, or accessing other applications while taking an exam, a browser lock software can be used. One issue on this is the software should be installed in the examinee's device for it to work. Number 2, use the exam security feature of a learning management system. Make the test only available for designated time, set the duration per item or the entire test duration, set to one item per page or multiple items on a page, randomly shuffle the items and alternatives, determine the student's ability to access after the submitted exam to get feedback or no access after submission, single attempt or multiple attempts, and a provision for exam password. And number 3 defensive strategy is authentication solutions. It can confirm the identity, authenticity, and presence of the person engaging in an online exam. The first line of defense in authentication is to allow only registered users to access the online exam. This is usually done by confirming the user's identity based on the user's knowledge of unique facts about himself or herself. Example, email address. A stronger authentication solution uses the user's biometrics, who the user is or what the user does distinctly, such as fingerprint, face, voice signature, and keystroke to confirm both the identity and authenticity of the user. However, biometric-based authentication solution requires special devices to read and match a user's characteristics. While user authentication solutions are simple and easy to use, they cannot prevent collusion and impersonation. Biometric-based authentication solution can only prevent impersonation at initial login. With the above concerns noted, a next-level solution is needed called continuous or presence authentication to ensure that the user stays put after the initial login. The following measures can achieve this. Video monitoring and or recording via webcam is a commonly used presence authentication solution according to Ampampa et al. In 2010. But additional devices for video recording and sophisticated software for analyzing video footage are needed using AI. All proctoring software still requires a natural person, faculty, or trainer to determine if there is cheating. So instead of using AI software, an actual proctor to provide continuous and presence monitoring of examinee is ideal. Why go through all these tedious processes? Again, Trudy Roberts stated the concerns about cheating behavior. Cheaters on exam are the ones more likely not to report medical errors. Cheaters in medical schools are more likely to fabricate clinical data. There will always be a question of their competence later on. Eventually, this will lead to the reduction of trust in the profession. Let me now go to the test security procedures recommendations from online testing centers. We may prevent cheating by communicating to all stakeholders the institutional honor code, the written guidelines to follow in online examination, and consider the strategies mentioned previously. We may detect cheating by looking at the data forensic and psychometric of the exam provided by the learning management system. Provide a proctor to monitor the examinee continuously. Some certifying bodies will also employ web patrol. Finally, we must act firmly on our decision regarding the consequence of cheating. Prevention and increased detection are key. There will always be new ways to cheat. We need to communicate the consequence of cheating. About data forensics. Data forensics or analytics are almost the same for all learning management system, Moodle, Blackboard, Canvas, and others. It can detect examinees' activity, how many times and how long exam materials were accessed, including the time of exam completion. Logs detects individual who can access before, during, or after examination. Live logs detects in real time individuals who are taking the exam. If the examinee says that they were logged out due to a connectivity issue, we can immediately verify if it is true. We can also see the name of the examinee and the IP address they are using in real time. About psychometrics. Built-in for all LMS is the psychometrics of exam results, including graphs, which allows us to detect outliers. It also includes item analysis. Again, it may not be the same format as what we used to know using the Scantron software, but we can manually derive the same format using the Excel spreadsheet. In conclusion, virtual assessment can be done and here to stay. There are a lot of challenges, but there is always a solution. As you can see, it means more work for us, training officers, and program directors. On behalf of the Board of Directors of PATOS, thank you very much for listening. You can reach me at my email address if you want further clarifications about certain concepts. These are my references. I am now ready for your questions.
Okay. That was my good friend, Dr. Warren Ruraldo. That was a very interesting and thought-provoking talk, providing us with a link, YouTube link on how to teach on an exam, online exam. So as mentioned earlier, we will go with a short open forum after his lecture. So the floor is open for questions.
Can I start with a question, Dr. J, for Dr.
Yes,
Warren?
yes. Actually, Dr. Solomon said that it was very informative.
No, I was just curious, Dr. Warren, in your institution, among the strategies that you mentioned, the preventive, defensive strategies, which among those are you actually applying in your university, and which ones do you think is very important and very reliable in terms of assessing the credibility of the examinee, sorry.
Yeah. Good afternoon, everybody. And of course, you have to follow to make sure that the validity is secure on all the steps. In terms of security, the most important is the proctoring. Really, you really need an actual proctor on proctoring the examination. As I said, we are using ExamSoft. It's a proctoring it's a proctoring solution or a proctoring software. But the downside is, yes, you can detect the number of items. They can say the number of activity na meron pwedeng cheating. Pero kayo pa rin eh. It's the person or the faculty who will decide really kung meron talagang cheating doon sa ano. So ano pa rin, titingnan mo pa rin. So another work for the faculty kahit may software. With regards to the browser lockdown software para hindi sila makabrowse and everything, ang downside lang noon is i-upload mo yon sa device ng student or ng examinee para mag-work yon. It can be done, but some issues minsan hindi kuhanan nung examinee. So dapat laptop, hindi pwedeng iPad, etc. etc. Yun, sir.
Thank you. That's very important. Iba pa rin yung human presence in
Yes,
the
sir.
interpretation of what they're doing. So do you also use different cameras during the exam?
Yeah. Bali, during the exam, kung video proctoring, so isang software or the LMS for the student taking the exam. So isang platform yon. Tapos isang platform for monitoring. Parang kung sa amin Microsoft Teams eh. So dalawang device ang kailangan. So isang camera, we determined that it should be positioned on the side. So meron pa rin mga so kailangan kita yung kamay, kailangan kita yung screen. Yun lang, no other device doon sa area ng examination. So yun, sir. Another camera.
Thank you, thank you.
Warren, how long is an ideal time to give a written exam online? Gaano katagal yung so as not to fatigue the examinee?
Yeah, the recommendation they say is 1 minute per item. So if it's 60 items, so 1 hour.
1 hour.
Kaya parang ang mga default ngayon in med school 120 items para 2 hours ang examination. But there's a requirement. The item should be more on the higher order thinking skill para wag lang recall kasi yung 1 minute mabilis silang so naboboard sila, pwede silang makakaisip pa silang mag-cheat. Yun. So the highest number na pwede na nakita ko is 200.
Wow.
200 item pwede. So I have not gone more than 200 items because sometimes sasabihin yung connectivity issue is there. So yun yung problema.
And then, yung attention fatigue, has that been studied? Yung student, concentrating on a certain exam for
monitor.
Yeah, for 200 questions, di ba? Ang haba nun.
Yes, sir. I haven't come up with a paper on that. Yan nga yung kasi sometimes yung mga student tingin sa baba. So tingin sa baba. So parang bakit may tinitingnan ka ba? Parang an act of cheating yan eh. Ang sabi nila na daw sila sa screen. Yung na-strain daw yung mata nila sa screen. Yeah. So yun yung kanilang mga alibi. Yun lang, yun yung So for me, I limit for our institution, we limit our exam to maximum of 150 to 200 per examination.
Doc Jeff, would you like me to read the question in the chat box?
Yeah, you can go ahead, sir.
Okay, from Dr. Gabriel Martinez.
Yes, sir.
What is the best LMS for the medical schools? Next question is, what are your thoughts on the 2-gadget setup, the LMS and Zoom, with multiple proctors to minimize cheating?
mahirap po yan yung the best LMS. Okay, so our institution is using Moodle. But parang ang sabi is all LMS parang isang open source lang yan. Parang pare-pareho din. Magkakaiba lang yung pangalan. So it doesn't matter kung what LMS ang kukunin. Pero in our institution, it's Moodle. If you use two devices, sir, kaya nga, internet connectivity is an issue. So kung remote proctoring talaga, so yung pagkuha mo ng exam will take up 5 Mbps, pero yung video monitoring mo will take 4 Mbps. The country or the institution na palaging they have done remote proctoring and parang doon natin ng pattern, doon namin pinattern yung institution namin. Isa NUS, National University of Singapore. So ganun sila ganun sila mag-proctor. So in their 1 proctor per 8 ang kanilang one proctor per 10 student ang kanilang recommendation. In our institution 1 per 8 because 8 lang yung kaya nung screen ng MS Teams. Pero later on pwede ng 1:15. Kaso nga lang pagka 1:15 mahirap na for the proctor to monitor really. Mahirap na. So 1:8, 1:10.
Okay, Doc Jeff, I think Dr. Chrysostomos is raising his hand.
Yeah.
I have a
Let me give the
question.
virtual floor to Dr.
I enjoyed
Chrysostomos.
your talk and congratulations on finishing an MH-Ped, like some of us here. I guess your experience is mostly with undergraduate students.
Correct, sir.
And therefore, sometimes you have a large number of examinees. No?
Yes, sir.
Now here, I'm talking about how it will apply to the different surgical specialties, especially the PBS, in general surgery, where maybe we have the largest number of examinees. Usually we average right bulk about 150 to 200 written examinees each year. Now, would it be possible, for example, to combine, features of face-to-face and online? You do a hybrid. You divide these 200 examinees at 10 examinees per site. You gather 10 examinees in a smaller area so that there is less chances of mass gathering and all of these potentials for protocol violation. And physically, the proctor is also there.
Correct,
So
sir.
then you make sure, for example, all the examinees in PGH will gather in one conference room, but the proctor will not come from PGH. It will come from another training institution, so that you prevent any potential collusion between faculty and the proctor and the examinees. Is that something more realistic, or maybe as a stepping stone to a fully online modality?
Yes, sir. I will advocate that, sir. The only problem there, sir, is the number of simultaneous user or concurrent user taking the examination. So kung kagaya niyan, PBS or SERES, that's 1,200. For RITE, that's 1,200. Kailangan yung capacity ng server, nagpa-quote ako dyan 38, 3,000 or almost 4,000 gigabyte ang kailangan nila doon sa IT, doon sa server. Yung mga med school, kagaya po namin, sa amin sa Lasab, may sarili kaming server. Meron physical server yung meron kami. Pero there are like Nifilia Web nagpo-produce sila ng cloud-based server. Meron nga lang pong bayad, sir. Pero pero pwede. The latest figure they told me is 600 per test taker. So kung mga 1,200, medyo mahirap na. Pero sir, if 600 less, konti lang yung server capacity, it goes down to 1,500 gigabyte eh. So kayang-kaya sir. Ang isa pang pwedeng gawin sir, wag pagsabay-sabayin. Yung first year ibang araw, second year ibang araw, third year ibang araw. Na-suggest na sa amin last time yan dun sa Ceres. Hindi namin sinunod. Yeah, hindi namin sinunod kasi yung exam question gawa na. So so different question yung gagawin namin. Pero I think that would be ideal, sir. Thank you, sir. Thank you for your suggestion.
Jay, there's another question sa Q&A.
Yes, sir. Would you like me to read, sir?
Sige, Jay.
From Emmanuel 11 Leyva. Are there any form of cheating before the pandemic, and what form? I'm just curious of why we are serious about this. Is there an existence this long time ago?
Meron daw ba nandadaya during the RIT or Ceres or PBS exam?
Wala po akong Wala po.
Maybe nobody can answer that.
Walang aamin, gano'n.
Another one from Dr. Leopold Lucero. Usually while proctoring an exam, the student's video and audio are on. Is there a way to control if extra noises like dog barking so as not to distract the other students? Okay.
Okay, sir, that's really a concern. Hindi pwedeng patayin yung audio and the video. So usually sinasabihan namin kasi may mga requirement. Kailangan isang room, quiet yung room, hindi So these are requirement that should be written in the guideline. Kasi kung hahayaan lang natin, like for example, take yung mga student one student, medical student, sabi na merong software na yung para umingay, yung mga construction daw, even without an actual construction, yun yung inaano. So ang ginagawa ng pinapatay yung audio niya. Yun sa kanya lang, not so as not to distract. Pero hindi rin po. Kailangan well-written yung guideline na kailangan quiet room. Meron pong software daw na ang noise construction. So talagang magagaling po yung ating mga estudyante. Yun lang po.
Doc Jeff, maybe to end this, I would like to address the question of our regent in charge.
Yes.
Sir.
From Dr. Paulino, our regent in charge, congratulations, a very informative lecture. Can listening the allowed time per question lessen the chances or attempt on cheating when given to residents? Is this method fair to the examinees?
Sir, the data lang kasi sir is if online examination, 1 minute per item. Yun lang, walang sinabi kung what would be the consequence for the exam taker. Yun po, sir.
Okay, Doc Jeff?
Yep, we can go.
So thank you, Dr. Warren, for that very informative and interesting lecture for us. Thank you again. So let me now call the first set of speakers and reactors from the Philippine Society of Colorectal Surgeons. So for our speaker for PSCRS is the Chairman Committee on Surgical Training of the Philippine Society of Colon and Rectal Surgeons. Let me welcome Dr. Hermanes Monroy III. Dr. Monroy, sir.
Yeah, thank you, Jay, and good afternoon to everyone. In behalf of PSCRS, the society under our current president, Carlo Cahucom, we'd like to thank PCS and Committee Surgical Training under J. Pusung and Regent Bert Paulino for inviting us to share our experience on the challenges, solutions, and innovations in surgical training during this pandemic and beyond. So let me share my screen. Okay. Just a brief introduction to our fellowship training program. PSCRS was founded in 1969 under Dr. Porfirio Recio and 9 others. And it took 13 years before the first training program was established in UPPGH. And this was a 1-year program. And under the leadership of Dr. Carlos Magsanok, the first graduate was Dr. Alberto Rojas. And it took another 19 years before the second program was established. And this was in Jose Reyes Memorial Medical Center under the leadership of Dr. Johnny Asprer. And the first graduate was Andre Abella. And then in 2010, the society increased or lengthened the duration of training to 2 years from 1 year to align with our regional counterparts, the ASEAN countries, in terms of the training program, particularly in Thailand, Singapore, and Malaysia. So the first program outside Metro Manila was established in Davao, Southern Philippines Medical Center, and this started the 2-year training programs for all programs. So currently, we have 11 accredited programs, but only 10 have active fellows in training. There are 8 in NCR, 1 in Calabarzon, 1 in Visayas, and 1 in Mindanao. The 8 in Metro Manila are the following with the year they started. Okay. So our programs are mainly based in big tertiary hospitals, university, DOH, regional, and also big private hospitals. So we have 1 in Calabarzon, the Batangas Medical Center, started in 2018. Our Vicente Soto Medical Center, which started in January 2020, unfortunately has no fellow in training right now. After 7 months, in the midst of the pandemic, the fellow contracted COVID-19 with severe illness and then became quite depressed, and so he resigned. Our training program in Mindanao is in Davao, the SPMC, with the affiliation with the Davao Regional Hospital. So what are the challenges that we face during the start and the midst of pandemic? Mainly, I think the same as the other surgical specialties. There was marked decrease in the operative experience of the trainees, particularly in the laparoscopic, endoscopic, and anorectal procedures. Maybe because initially these procedures were thought of as really aerosolizing procedure that could infect surgeons, but eventually we realized that this is not as infectious as upper GI endoscopy or tracheostomy procedures. So based on the submitted annual reports of the 10 training programs, this is how severe was the effect of the pandemic to the volume of procedures. We have 3 major categories that we require. So for major abdominal procedures, which include open and laparoscopic, the percentage decrease in the volume across all programs ranged from 44 to 65%. Anorectal procedures were more severely affected, and the percentage decrease ranged from 64 to 85%. And so with colonoscopy, which decreased to 58 to even 100% in one training program. So even in our high volume centers, these were the numbers reported. So 2019, the year before the pandemic. So these are how each category was affected by the individual programs. So SPMC was severely affected. We noticed that once you're recognized as a COVID referral center or a COVID hospital, patients will not go to you, especially during lockdown. And these were almost all our training programs are considered COVID hospitals. So in PGH alone, the bread and butter of the program, which is colon and rectal cancer resections, we do at least more than 400 major surgeries in 2018, 2019, and it went down to half in 2020. And as in the first quarter of 2021, we were slightly going back to the pre-pandemic numbers, only to be halted by the surge in April. So it looks like the trend is we will just fare the same as 2020 or just a little over the numbers of 2020. So the effect of the pandemic also was seen in the two private medical centers or with the training programs, and almost the same percentage decrease as the government training programs for both TMC and St. Luke's. So other challenges include COVID-19 infections among fellows. This was a big challenge. 7 out of the 17 fellows got infection while doing their duties. Fortunately, 6 out of the 7 were just mild, but 1 developed severe type of COVID-19 infection and eventually resigned. And fellows were also required to handle patients who are suspected or confirmed COVID-19 patients for surgical evaluation, and if emergency procedures are needed. So really, the fellows were really put at risk during pandemic. And 5 out of the 7 senior graduating fellows at the end of 2020 were extended and did not graduate in 2021. They were extended for a year. 2 were able to finish after 2 months and 6 months extension respectively. So this is another challenge that our fellows have to face up. And an important component that they miss is their international rotation or exposure. This is a 3-month rotation, usually with our linkages in the region and even in the United States. This is a very important component that they miss. So what are the solutions and innovations that the society and the individual programs have done to compensate or address the challenges? So we encourage and allowed more private cases of consultants to be performed by the fellows to increase their operative numbers. Each program has their own telemedicine platforms, through social media and hotlines to increase their patient consults. There was proactive involvement by most of the consultants in their own hospitals in terms of the resumption of surgery and non-COVID services. And this is important for the service not to be left out during the resumption. And we encourage more use of the simulators, and of course, everyone use virtual webinars. And to compensate for the non-rotation internationally, we invited our friends, experts from abroad to participate in the webinars. So one of the very useful and I think very important solution that we were able to do is a virtual joint conference. We usually do this, at least 3 or 4 programs will meet every other week or once a month before the pandemic. And then this was performed virtually. Eventually, this evolved into participation of all the programs nationwide. And this became a venue for many activities like special lectures, workshops, assessment of training programs, journal clubs. So this has been a very important activity for the training of our fellows. And Ryan Abari will expound on this, and this can be replicated by the other specialties. So in PGH, our fellows initiated their own teleconsulta hotlines. This is in addition to the hospital's online teleconsult platform. And the society was able to conduct a hybrid convention or scientific meeting last March with a lot of participation of international faculty. So there were only selected attendees, and this was held in Eshashang. We conducted at least 4 webinars with international guests throughout the year. And also through the leadership of Sir Armand, we were able to have face-to-face diplomate written and oral exam last March. So I think in summary, our programs were really hard hit by the pandemic in terms of a marked decrease in the volume of operative and diagnostic procedures. Our fellows are training clinical experience were severely affected. Some even got infected, suffered psychologically or mentally, and were extended in their training. PSCRS and the different programs have proactively employed solutions and innovations to address these challenges. Although the pandemic has separated us physically in the society and the different training programs, I think this has made us closer virtually and in spirit as we try to monitor or look more closer in the training, different training aspects of our fellows and the institution, different institutions. Thank you.
Thank you, Dr. Monroy, for your sharing. To react to Dr. Monroy's talk, we have 2 reactors. So our first reactor is the chairman of the Philippine Board of Colon and Rectal Surgery, our past PCS president, Dr. Armando Crisostomo, to be followed by the reaction from a training officer from the section of Colon and Rectal Surgery, Department of Surgery, Quirino Memorial Medical Center, Dr. Ryan Rainiel Abari. So would like to give the floor now. Oh, we have 3 reactors from CRS. The last reaction will be coming from a fellow in training from the colon and rectal surgery of PGH, Dr. Joanna Pauline Baltasar. So to give the floor, I would like to call on Dr. Crisostomo for his reaction.
Good afternoon to everybody. Is my screen visible to everyone now?
Yes, sir.
Okay, thank you. I'm speaking from two hats. One hat is as chair of the Philippine Board of Surgery to share a little of our experience. And likewise, as maybe one of the most senior among all of you, among all the panelists here this afternoon. And that's why I labeled my reaction as key learning points, hopefully not just from the side of the colorectal surgeons, but for all the surgical specialties as well. First of all, as mentioned by Dr. Monroy, we conducted our certifying examinations face-to-face, mainly because we have the luxury of only having very few examinees. Like the last exam that we conducted last March, we only had about 11 examinees, and that's already 2 years graduates because we failed to conduct any exam last year. So this is a picture of the written examinations. Of course, we can see that our examinees are quite a distance apart and very luxurious because it was held at the EDSA, where we had the hybrid convention of the Philippine Society of Colorectal Surgeons. And because of the few examinees, we also have the luxury of conducting the written exam in the morning. Then we check the papers right away, and those who pass proceed to the orals, which is held in the afternoon. Okay. These are pictures of the oral examination. You can see there, here is Dr. Omar Ocampo, Dr. Kahukom, and we have here the terror in the batch, Dr. Bobby Bandulon. And then we have 3 panels. One, the anorectal panel, which is about hemorrhoids, fistula, and the like. The benign colorectal disease, and then the third panel is the on colorectal cancer. Our examinees have to pass all 3 panels, 3 out of 3. Okay. Now, what we do is we usually, even before this pandemic, we would hold our examinations at about the time that the Colorectal Society holds our annual convention. This will enable, because some of our examinees come from provincial areas, no? So that they attend our convention at the same time. Just before the convention, they sit for their examination, so that they do not have to spend so much in traveling to Manila, which is the usual venue of the examination. This is our PMA representative who acted as observer. As you know, we would like to thank the Philippine Medical Association. I suppose all of us had to adjust to the PMA guidelines, but they were very accommodating, and this guy was a representative of the Mandaluyong Medical Society, since the venue of the examination was in the EDSA, which is located in the city of Mandaluyong. So key learning points. Number 1, I think in this time of a pandemic, all of us need to collaborate, or as I mentioned, kailangan cooperasyon. Collaboration rather than competition is the order of the day. I'm sure the time was when training programs would sometimes compete with each other as to who would have a higher proportion of passers in the exam, who would top the exam. All those things should be thrown out, and we should see really more collaboration, not only among the different training programs within a specialty, and we have seen this in colorectal society, as Dr. Monroy mentioned. We have even become closer because of the pandemic. And Dr. Ryan Avery, who is one of the prime movers of our common conference, will describe this in more detail. But even we should learn, we should collaborate between specialties. And I think forums like this are very useful, because they will enable us to share best practices. And, wala namang may monopoly nun, hindi naman patented yan, wala namang ano yan eh. Copyright yan ng mga ideas natin and innovations that we introduce to improve our training and to how we conduct our examinations as well. No, so really, we should be really sharing all these ideas, and even between different specialties, between surgery and other specialties. And I will cite as an example our anesthesiology partners. I think for quite some time, they have really become the pioneers when it comes to administering not only written examinations, but also oral examinations, and even practical examinations online. Secondly, I believe our partners in anesthesiology are also the pioneers when it comes to recertification examinations. As chair of the Surgical Specialty Boards Council, this is one of the things I am trying to push, that eventually we in the surgical specialty boards come to an era wherein we will now require recertification among our fellows or our diplomates to ensure that we can give the public, well-qualified and competent surgery. Because as I see it, if pilots who fly our planes are required to certify every so many years, I think surgeons should be required to do so as well. And we can learn much from our anesthesiology friends on how to conduct recertification. Second, there is a call for greater flexibility and creativity or innovation. I think we should rid ourselves of being so rigid in our requirements. I think we should be flexible enough to allow training programs to develop innovation so that they can produce competent graduates. Like, for example, increasing the number of procedures. In the Philippine General Hospital Department of Surgery, let me share now that a rural surgery program is being worked out with a hospital in a provincial location with a sufficient number of cases, because as you know, in PGH, we were really hit hard by COVID. Half of the hospital was converted into a COVID hospital. So we had really less number of beds for non-COVID cases. And then, as you know, nagkasunog pa. So operating room pa nagkasunog. So it even further diminished the number of cases that our surgical residents will be able to do. And so, we now, our chairman, Dr. Jojo Arcilia, has reached out, and it's a win-win situation. Our consultants will volunteer to supervise the residents in this provincial hospital. The residents will be able to do their procedures, of course, under consultant supervision, and then they will be able to improve the services of that particular provincial hospital. But if we become so rigid and unflexible, that would not be allowed by current rules of accreditation. Sasabihin, ay, hindi naman accredited yung ospital diyan sa probinsya. wala silang accredited Department of Medicine or department, yung mga ganun mga requirements. Sometimes we have to, give up on those that will not really affect the outcome, and that is related to my last year. We are living in the age of what we call an outcome-based curriculum. What is important is the outcome, or what our residents or the products of our training program can and should be able to do at the end of their training. There is less emphasis on process. Most important is, of course, to be able to discover and find out whether they can competently perform the expected outcomes. And evaluation, therefore, is going to be very important. We should not expect residents to be learning all at the same time, at the same pace, and parang like a factory. There will be residents who will be ready earlier than others. And so we should be ready to evaluate and find out on whether they can achieve those outcomes. And again, flexibility is also expected on the part of our hospital administrators. As Noning mentioned, we have had to extend some residents. An inflexible hospital administrator may not allow that, di ba? Yung magpapasweldo sila for an additional few months or to a year after the so-called graduation of a resident. So it's important, and I just try to show this. Do outcomes really matter? Of course. Everything hinges on making sure that our residents are achieve the necessary outcomes, and we have to be more understanding and compassionate, because our residents have become really, the challenged frontliners. They are exposed directly more to patients and potentially COVID patients more than us, more than the consultants. And so really we should not only be flexible, but compassionate as well. So that's it. Thank you.
That was a very thought-provoking reaction from Dr. Crisostomo. Dr. Abari, the floor is yours.
Good afternoon. I am Dr. Ryan Abadi, and I was tasked to react in this talk. First and foremost, I would like to thank the Philippine College of Surgeons for giving me the opportunity to share my perspective with regards to this topic. And I really do believe that innovation and evolution can be optimally achieved through constant collaboration. I have no significant disclosures in this talk. Instead, I will be disclosing that I am not a seasoned educator, nor am I also great with numbers and statistics, but I do like to tell a good story. But as a sports fan myself, nothing is a greater story in the Philippines than the sport of basketball. I have likened our journey in PSCRS to this sport as it mirrors the entertainment and excitement coupled with future developments in this sport to our organization. As of date, we currently have 10 strong accredited colorectal training programs in the country. Colorectal surgery training has been established in this country since 1969, with the Philippine General Hospital or GS2 leading the way since its fruition. It is not only after 20 years from now that the second training institution for colorectal surgery, Jose Reyes, has been established, and since then, numerous training programs from this two stronghold, or as I may say, players, that other colorectal programs develop and flourish. And needless to say, everyone of this training institution wants to be like PGH, which is considered as the hub of colorectal training in the country. Yes, everybody wants to be like Michael Jordan. With varying and multiple colorectal training programs in the country beginning to thrive, leaders and mentors of PSCRS began to conceptualize how we can bridge and identify strengths and weaknesses of each program. Yes, strengths are good, but eliminating weakness removing the term uniqueness like operations and terminologies that distinguish training institution, words like uniquely PGH, uniquely JR, done in Quirino, done in SPMC, and branding it as one and united PSCRS brand has been the challenge posted to our small society. And as such, the answer to the call is to do an inter-hospital conference. Logistics such as time, place, and topics to be discussed were set. Colorectal consultants of all training institutions in Manila were invited to participate. It started as a 2 or 3 colorectal training programs, meeting every week or every other week thereof to discuss census and preoperative conferences that gives valuable insights to trainees then, such as me, by colorectal consultants. I remember as my mentors would say, you are not a graduate of only one institution but a product of different training programs. Some may call this unprecedented, others may call this overachieving and biting more than we can chew because of schedules and topographic logistics. But looking back as a trainee, I call this commitment for the betterment of colorectal surgery in the Philippines. The then 2 or 3 colorectal training institution became 5 to 6, mostly made up of colorectal training institutions in Manila. Venues were rotating, and I was amazed by the turnouts of not only fellows in training, but also of fellows of PSCRS who showed commitment of their time every Friday to see, discuss, and advise on different colorectal dilemmas facing each institutions. Moods were lively, discussions were inspiring, and unity was forged through constant repetitions of these meetings. We would always have some after session conferences with fellows and consultants, and even in these after work sessions and merrymaking, can you guess what's the topic? It's still colorectal. It was truly awe inspiring, and I really do believe that we were headed into the right path, but there is still something missing. Yes, meetings were only held in Manila, so training programs in different regions were left out. Looking back, for one to be truly world class or international, there should be no one left behind. National unity and collaboration of all people involved in all training programs should be the first priority. But then, the pandemic of biblical proportions happened. A nightmare seen only in movies occurred. COVID relegated all of us to our homes. Specialists and generalists were indistinguishable on how to fight off this new deadly virus. People were isolated, families were separated, operations were halted, meetings were postponed indefinitely, and life came to a full stop. But then, as imprinted in our own genes and nature, human beings are social. We would have to find a connection, be it physical, emotional, and now literally web based social media to find a meaning to what we do every day. Platforms and new technologies have given us a way to be connected at the tip of our fingertips. And yes, the world now is socially small and is literally in our hands. And real life possibilities can now be transformed to virtual realities. Combined colorectal meetings started 3 months after the pandemic hit as a way to connect us to each other. It started as a way of semblance to our past lives so that fellows in training and consultants of the PSCRS will be interconnected through web-based platform. The combined colorectal meeting was now further in its reach through the helms of technology and interconnectivity. Now all of the colorectal training institutions are able to participate, discuss, and contribute to each and every institutions. It has bridged the learning for new trainees that even seasoned and senior consultants are able to participate and share their experience and expertise in colorectal surgery. The combined colorectal meeting also serve as avenues for new learning activities for the fellows. Basics and Beyond core lectures were aimed to supplement and update fellows in training and consultants through keynote lectures from different experts, not only colorectal surgeons, but from the different departments in the field of colorectal surgery. It has proved to be a new, fruitful, and exciting learning activity for the PSCRS. And in the recently concluded international scientific meeting, the fellows in training were given the session called the Colorectal Compendium. The Colorectal Compendium served as a showcase of each and every institution's capabilities through different video presentation as a way to bridge and share their different operative experiences in the field of colorectal surgery. And just like in basketball, locker room strategies are important for the next step. The combined colorectal meeting served as a medium to guide fellows in training through their researches, as each fellow was given a mentor and reactors to their chosen proposal where changes can be made. This also provided an avenue to produce quality, multi-center studies that not only can be published nationally but internationally as well. And as far as in-game huddles and coaching, live surgery and video mentoring of colorectal surgery cases has provided a new way for teaching fellows and residents. Basic and laparoscopic colorectal cases done by experts that would have been difficult to envision pre-pandemic. Another is the unedited recorded surgery review, which has provided a non-biased and technical evaluations of steps missed and procedures done well in a non-judgmental and a conducive learning environment for fellows, residents, and students. And yes, the potential in this time, day, and age is full of infinite possibilities. With all of the help of the old and the new, the experienced and the novice, I think we could be like Mike. The PSCRS can show its true potential not only nationally, but all throughout the whole world. Because I do believe that even in the midst of all this cataclysm and confusion, we can only grow stronger when we are together. Thank you and have a good day.
Thank you, Dr. Avery. Dr. Baltasar, the floor is yours.
Good afternoon, everyone. I'll just share my screen. Thank you to the PCS Committee on Surgical Training for allowing me to share my experience as a trainee during the time of the pandemic. So actually, Dr. Abari and I didn't talk, but I guess everyone still has gotten over the recent NBA season. And actually, my theme is also about basketball. But just a disclaimer, I don't play basketball and I haven't followed basketball in the recent years, but here we are. So training in the pandemic is something I consider like off-season training. In off-season training, it has its own set of challenges. Definitely during this time, we had less patients in the OR or less time in the OR and less patients. And of course, the pandemic also posted a unique set of health risks, which we never really had to think about before. But this also opened up more time for renewing our strategy and rethinking how we go about things. So a colorectal surgery fellow, I always thought of it as a player coach, someone similar to Bill Russell. So Bill Russell in his final years in the 1960s played as both a player and a coach. And during this time, he was able to bring his team to 2 championships. And particularly in the Philippine General Hospital and particularly in colorectal surgery, the fellows are really encouraged and expected to be both a player and a coach. A player where we try to learn new skills, and a coach because we're very much hands-on in dealing with the training of our residents as well. And this is something that during the pandemic was really highlighted. So now that we're talking about basketball, let's talk statistics. So these are our statistics. The first 3 are our statistics, my statistics for the year and a half that I've been training as a colorectal fellow. And the one in yellow, the column in yellow with the green numbers, show the numbers of the fellow that finished before me. So she started pre-pandemic and ended during the pandemic. And the red column shows our requirements as colorectal surgery trainees. We can see here that we're still able to meet the requirements of what is required to be a colorectal surgeon. However, we can also see, and as Dr. Monroy presented before, the statistics are dismal compared to what they were before. Here we have our major surgeries, and even more dismal actually is our anorectal procedures. This is of course understandable since these anorectal procedures are more elective, and we don't expect patients to brave the storm of COVID just to get these procedures done. But what's also evident here, we can see here that colorectal surgery fellows, particularly also in PGH, are very strong on assists. In fact, personally, I consider myself the John Stockton of the department. If we're looking at assists, I would think that colorectal surgery fellow has the most number of assists in assisting junior residents as well as their consultants. And we're very lucky to have this opportunity because I think one of the biggest things in training that we get to learn from is assisting both junior residents, and we're able to teach them as well as learning a lot from our consultants. And so in terms of the pandemic, we had to be, as Dr. Armand Chrysostoma said, we had to be more creative. So we had to shift our strategies. If we were training for basketball, we would look at it as getting out of the court and looking for alternative training sessions. And some of these that we were able to do was, number one is out of hospital procedures. I was very lucky to be able to assist one of my consultants in a different institution. There, of course, I was able to learn about the procedure, but I was also able to experience what it was like outside of the hospital. I got my GS training in the Philippine General Hospital as well, and I took my undergraduate studies there. So basically, most of what I know is just basically what happens in PGH. But because of the pandemic, I was able to get that opportunity to assist my consultant outside of PGH. And another opportunity that we got into was online mentorship. This is an example of one of these, and I'm very lucky that our consultants are also able to open up opportunities for us. This is a mentorship session that we had with consultants from the National University in Singapore. And here we're able to present laparoscopic videos that we of the operations that we performed, and they gave us very practical tips on how to improve our technique, certain tips and tricks. And this is something that we don't normally get the opportunity to do, but we're able to get this kind of exposure. And that is all thanks to very committed and supportive consultants that we have. Aside from that, we also have the laparoscopic and the robotic simulator in the hospital. And as Dr. Avery said, we also had bi-monthly joint colorectal meetings and lectures. And also, we were also, well, I guess now that we have more time out of the court, out of the operating room, we've had more time for research, which is usually something that we drag our feet in doing. And also several video presentations that we were able to do in international fora, such as the American College of Surgeons and the American Colorectal Surgery Convention. So now going on the offensive. Um, Now that we are in a different challenge, usually we go on the defensive, we practice safe surgery, we um, stick to the principles. But now that we are in a pandemic, we were pushed to go on the offensive. And these were the strategies that we did. And number one was, as Dr. Monroy said, we became more aggressive in trying to get more patients, trying to involve more of the patients that we don't normally get in our outpatient department by widening our reach. So we used social media, we used Facebook in order to reach more people, to be able to reassure them that in spite of being a COVID center, Philippine General Hospital is safe and is open for colorectal procedures. And aside from that, I'm also very lucky. This is a post from our training officer, Dr. Lopez. You can see the date is June 4. So 3 months after the pandemic started, after we became a COVID center, we were able actually to open our operating rooms and start our operations for colorectal surgery and even other surgical services. And I'm very thankful because this part of going on the offensive came from our consultants. They took active roles in the hospital so that we'll be able to control our fate and be able to go back into the courts earlier than expected. So another thing that I believe bothers most of trainees, whether it's general surgery residency or fellowship, is training extension. So training extension, as mentioned before, has really been a challenge, especially for people who already know what they're going to do after training or have already plans further after training. But as in any basketball game, everybody is tired by the fourth quarter. But sometimes in the overtime, that's where the best plays happen. And so if there are any trainees listening, I'd also tell them to be open to having an overtime because you'll never know what kind of opportunities will spring up from this training extension. And we're very lucky because training extensions usually mean extension also in salary. So that's always a good thing. Okay, so some game highlights that I've had for the year and a half that I've been a colorectal fellow. The first two is learning endoscopy and learning new procedures. So even in spite of the pandemic, in spite of the limitations, I was still able to make the most of the time that I had as a fellow. And definitely, I was able to learn new techniques and new procedures. And the good thing about having, I guess, less patients and more time during the pandemic is that we're able to really take in the procedures and the things that we do on a daily basis. Before, the colorectal service was very busy. We can see from the numbers, and we can also see from the appearance of the rotators and the fellows before, that it really took a toll on everybody. And people were just doing things just to get things over with, to operate on the patients, to finish everything that needed to be done. But now we had the time to take it in, to evaluate each operation that we had. And this has translated into less morbidities and less mortalities. Of course, with less operations, you do get less morbidities and mortalities, but we're also able to really assess each operation and focus on the technique rather than the numbers. Other game highlights are the support, supervision, and the feedback of our consultants, and of course, our junior residents. Our consultants were the first to provide us fellows with the proper PPEs that we needed. And of course, supervision is still there, in spite of all the risks that these consultants, some of which are older, may get from going into our ORs. They still do, and they're very active in supervising our operations. They're always there if we need anything when we're faced with difficult procedures. And also, another game highlight is participation in foreign and local conventions. As mentioned, we were able to, since we do have more time, we're able to prepare and increase our submissions in foreign conferences. And of course, that's always a highlight of any trainee. So, okay, so this is my last slide. As I mentioned, maybe my references in basketball players are a bit dated, but I guess this is current. This is Chris Paul, and if people follow basketball, we know he just lost a championship game that everybody was rooting for him to win since he's reaching his retirement age. But this is a guy who refuses to retire in spite of his advanced age. And this is what I hope the message I could bring is that we all have our own losses, particularly in this pandemic, loss of patience, loss of time, loss of our health maybe. But the message is don't settle with your training. This is the only time we have for training. We only have 2 years of this and a bit more months. But we shouldn't aim to finish, but we should aim to win. So that's it. Thank you very much for this invite.
Doc Jeff?
Great. I think
Yes.
the
That
Learned
was
a lot.
our basketball fanatics, colorectal surgeons.
Team effort is very important. So, and that was the PCSRS for you. So for our next set of speakers and reactors, allow me to introduce to you the representatives from the Philippine Society of General Surgeons. We'll start from our speaker, Dr. Deogracias Reyes. He's a general surgeon, of course, the chairman of the Committee on Surgical Training of the PSGS. Dr. Deo, please.
Good evening. And here are my slides. Thank you very much for the PCS-CST for Dr. Pusong and Dr. Paulino for the invitation to share with, for the opportunity to share with the group the innovations that the PSGS has been implementing during this pandemic. Earlier, we were talking about multiple gadget, web-based proctoring and other proctoring software using one, two, or multiple devices. Prior to the pandemic, the PSGS has undergone a project which is known as the Hybrid Online Learning System, which takes off on the concept of using multiple devices to monitor, teach, and learn at the same time. So the hybrid learning system is composed of several components. First will be an online pretest. Second would be a set of 13 to 17 recorded videos, an interim test. Pre-pandemic, it was a face-to-face. And then fifth and last was a post-test. The driver behind the hybrid online learning initiative was not really to cope with the pandemic as it was started before the pandemic, but it was really an effort to standardize learning and teaching of laparoscopic skills. We wanted to shift from how I do it to what is the best way and best practice in as far as laparoscopic surgeries was concerned. So we came up with this structure. And technology, just like in laparoscopic surgery, made it very real and very possible to do. So after the 2017 revision of the curriculum, 2018 it was the first run of the hybrid online learning system. And we were able to launch a validation study. But come 2019, because of the pandemic, the face-to-face was not possible anymore. Before, a set of faculty used to go around the different chapters of the PSGS to do the face-to-face. And therefore, the hybrid online learning system became and evolved more to having the virtual face-to-face during the pandemic. So we talked about multiple devices for teaching and learning. This is how the hybrid online learning system evolved to be a more complex teaching learning exercise using multiple gadgets and taking advantage of today's technology. Before the pandemic, teleconferencing used to be a very expensive endeavor, necessitating teleconferencing dedicated equipment and very large bandwidths required. During the pandemic, Zoom and other applications improved and became so easy to use that the following structure that I will describe to you has become possible. So the setup is to have a plenary session every training period or every face-to-face period. And then a faculty will be assigned several residents and they will be going out to a breakout room. So the faculty will have 3 cameras and each resident or each trainee will have 3 cameras as well. And the setup looks like this, right? So camera 1 basically shows the resident's body and how the resident is performing the task. Camera 2 is a view of the box trainer and what is going on inside. And camera 3 basically focuses on the hands and the instruments of the resident and the trainee. The faculty will have the same setup. So if the faculty will need to show how a maneuver is better done or to show certain refinements to the technique of the resident, the faculty can be observed in the same manner that the students or the residents can be observed. His instruments, his posture, and his hands can be observed as well. So this is a quick video capture of two residents undergoing the same drill. There is actually a third camera that can be viewed per resident that will be showing the posture of the patient. And here I am trying to look very interested and giving pointers as they go about the exercises. So it has been very useful and we have had very good success in as far as the hybrid online learning system is concerned. And the society, PSGS, is about to finish a validation study on the pre-pandemic iteration of the hybrid online learning. After which, a validation study again of the virtual face-to-face of the hybrid online learning system shall be undertaken by the society as well. Next is the residence portfolio. This is another initiative that was started pre-pandemic. It was initially thought of to give and empower the residents, to give them more control and have greater ownership of their training. It's basically them putting together their own portfolio to speak of their training and their learning. Unwittingly, during this pandemic, it becomes a more efficient tool in trying to find out and trying to get to know how the residents are faring because all the necessary supporting documents and exercises are already put together by the resident. So again, unwittingly, we found out that the resident's portfolio has become an even more important tool in assessing our residents more than it was initially envisioned pre-pandemic. This is how the soft copy of the resident's portfolio. Currently, it is a manually inputted hard copy based portfolio, and perhaps because of the development of technology and again the requisites of training programs in the times of pandemic, we will be moving on to a computerized and web-based residence portfolio format. So I guess this will be the meat of my topic, and this will be on the provisions for accreditation and eligibility of our residents, for which I prepared a mind map, which I will share with you as well. Can you see the mind map? I guess you can.
Yeah, we can.
Okay, thank you. So the first part will be on accreditation. The Committee on Accreditation has been very judicious in determining the needs and desires of the training programs and to input some order of flexibility in as far as accreditation. Although the 170 cases for every 5 residents in the 14 categories was maintained, the percentage of private cases that can be accredited as cases for the residents was increased from a pre-pandemic of 35% to 50% per category during the pandemic. Surgical missions before can only have about 20% of the total census per category accredited. During the time of pandemic, all cases done during surgical missions will be credited. Service cases were always required. Every resident should have, or every training program should have at least 20% of their cases done as service cases. This requirement of 20% of total cases done as service cases was waived during the pandemic. Regarding outside rotations before were limited to two categories, meaning to say every outside rotation can only be used in two categories. So now, outside rotations may be applied to cases for more than two categories. Cases done outside shall be outside of all accredited hospitals were required to be covered with a MOA. There are interim programs in PSGS, meaning to say programs which have just started and have not yet achieved full accreditation. During the pandemic, cases done in interim training programs as an outside rotation done under the supervision of a PSGS fellow under good standing will now be accredited as a case for the resident in training. Of course, covered again by AMOA. Cases done in non-accredited training programs, yet done under the supervision of a PSGS fellow in good standing, are now counted as well for the cases of residents in training, yet still needs to be covered by AMOA. 50 years who are usually expected to stay in the base institution can now do cases outside the base institution and shall be credited to their count. Again, under the supervision of a PSGS fellow in good standing and covered by AMOA. For accreditation, going to the different training programs proved to be quite impossible. So for the 2020 annual report, a rubric assessment of the annual reports was implemented with no physical visits required unless determined by the committee. Now, for eligibility, there are still 100 cases for 8 categories that will be required. And cases performed outside the training program, again, as I've earlier mentioned, applies to eligibility as well, not only to the accreditation of the training program. Cases done in interim programs as well, just like for accreditation, shall be counted for the cases of the resident. Likewise, for non-accredited training programs, for as long as the case was done under the supervision of a PSGS fellow in good standing and covered by AMOA. 5 years for eligibility can have their cases done outside the base institution counted for their eligibility to take the PBS exams as well. Now, in as far as graduation is concerned, if the operative deficiency or operative case deficiency is less than 10% per category in no more than 3 of the main categories, and for as long as the index cases are performed within the 5-year training period, the resident may be allowed to graduate. And the completion of the deficiencies should be done rather, within 2 years after graduation. And this entire undertaking shall be under the supervision of the training officer or a PSGS fellow in good standing. Now, if the operative case deficiency seems to be greater than 10% per category in more than 3 categories, and the index cases within the training period are deficient, then it is moot and academic for the resident to be retained. But the completion of the deficiencies, rather than being given a deadline, is now placed under the discretion of the training program. And again, under the supervision of the training officer or a PSGS fellow in good standing. So as far as my presentation for PSGS is concerned, that will be my last slide. Thank you very much for your time, and your attention was much appreciated.
Thank you very much, Deo. That was very enlightening and very helpful to all the training programs.
A lot of questions.
Yeah, I'm expecting that. So After your talk, we'll now go to the reactions. So our first reactor would be Dr. Jose Solomon, who is the chairman of the Department of Surgery at Veterans Memorial Medical Center, and likewise the chairman of the Committee on Accreditation of the PSGS and PBS eligibility. Our next reactor, of course, will be Dr. Orlando Ocampo, who is known to all of us. He's the chairman of the Philippine Board of Surgery. And lastly, our last reactor would be the president of the Philippine Association of General Surgery Residents, who is Dr. Corina Blanca Garcia. So may I now call on Dr. Solomon, please?
Yeah, thank you, Jeff. Can I have the last slide of Deo? Ayun yung reaction ko eh. Okay, I'll just
Okay, sir. I'll just
expound on some items. Yan, very good, Deo. Thank you.
Okay,
Because
sir.
only informed by Albert 2 days ago, nakasama pala ako. Anyways, yeah, I think this is fair enough. A little history. This was formulated most likely around the start of the pandemic, nung nasa ECQ na ang Metro Manila around mid-March to, progressing to hanggang tuloy-tuloy na. And the board decided to have a census among the programs and what have been happening during this pandemic. And the board inutusan kami, Committee on Accreditation, to formulate guidelines on how to help the programs during this pandemic. And okay, as far as accreditation is concerned, the minimum case requirement stayed. This was decreased from a previous of 200, okay? 100 major and 100 medium, divided among 14 categories. The private cases credited 50% from a previous of 35. Someone even asked, why not 100%? And I answered him, ginagawa mo ba talaga yon? Okay, so let's settle sa 50% muna. As far as the surgical missions are concerned, these are out-of-hospital missions, okay, sa labas to. If in-house, 100% of cases will be credited. But this is out of hospital mission, so all surgeries were credited, and the 20% service cases requirement per category was waived. As far as outside rotations concerned nga, a previous maximum of 2 categories, they can just rotate. Sasabihin na lang nila sa kanilang MOA or MOU, GS rotation. That's it. That's okay. So cases outside of the MOA shall be credited, and the interim programs, which started 2020, only catered to first-year residents. Okay? So yung mga kaso na for third year, fourth year, and fifth year, pwedeng i-claim yan ng outside rotators coming from accredited programs. As long as, preferably, yung consultant mo from the base hospital is also a consultant in the interim program. Preferably yon. Pero if not, pwede namang basta PSGS fellow. Okay? It should be covered by a MOA or memorandum of understanding is okay. Kasi pag MOA to, it is a local government, natapos na yung rotation, hindi pa nagagawa ang MOA. Okay? So medyo lenient kami dyan. For non-accredited programs, pwede na. Yung mga maliliit na hospital dyan, pwede na as long as supervised by a fellow with a proper operative care. And not only will the fifth year can rotate outside the base institution kung talagang kailangan niya ng kaso. The rubrics was used for 2020 annual report, and not surprisingly, it seems to be a lenient scoring system. Even if you have deficiencies in 2 or 3 categories out of the 14, you may still pass, and the minimum passing is 60. As long as you pass all the 6 categories, your accreditation will be continued. As far as eligibility, okay, we're in the process of uh, uh, evaluating the application of residents, most of whom graduated 2020. Okay, and as of now, we have 442 applicants. 126 have been endorsed and 16 pending, and we'll have our last meeting on July 31, and the final list will be submitted to the board and then certificate eligibility to the PBS. So basically, ang eligibility accreditation, magkatugma yan eh. If it affects your accreditation, it also affects your eligibility. Okay. Etong last two items, this is not absolute, okay? This is not absolute, the last two items. If the operative case deficiency is less than 10% per main in no more than 3 categories, index case are, okay, you may do it, you may graduate the resident and satisfy his requirements outside, okay, the base hospital. 2 years after graduation, this is not absolute, okay? Can be less than 1 year, more than 2 years, hopefully better, less than 2 years. If the operative case deficiency is medyo significant, more than 10% per main category in more than 3 categories, and index cases are deficient, the original idea was, wag mong pag-graduatein hanggang complete ang deficiencies. But this is subject to discretion of the program. We leave it to the training program. Kung pwede nang bitawan to, isatisfy ang eligibility requirements. We have been we've had 2 meetings sa eligibility, and more often than not, ang nagiging issue lang is documentation. Pag nagkakaroon ng problema sa kaso, talagang significant problem, we call the applicant, what happened, blah blah blah, what happened, ano ba, wala ka namang makuhang kaso, okay, wala ka namang makuhang kaso, wala ka namang makuha, okay. So for the index cases, as much as possible, you have to satisfy them, but yeah, because of this pandemic, and we expect the census or the eligibility requirements to fall short compared as last year, kasi ngayon yan ang effect ng COVID eh. Ang kawawa ngayon yung mga seniors eh. Kung i-extend mo yung mga graduate supposedly, it's a domino effect, maubusan naman tong mga that's why if ever kaya nga lumabas tong mga requirements na to. So as far as the index cases are concerned, nakita namin na may mga nagawa naman siya o na-assist na index man lang, if ever, we are kind of lenient with regards to that. Basta may exposure, nag-assist na bantayan ng maayos, we are kind of lenient this year. Okay? And I think for the coming years, Okay, so this is one, I think we have been lenient. MOA is okay, an MOU is okay. Minsan ano lang a letter of agreement lang between the base hospital and the receiving hospital, it's okay as long as for legality purposes. Ang importante lang is the consultant is there supervising the resident or the graduate, and there is proper perioperative care. That's it.
Thank you very much. May I remind everyone to please write your questions in the Q&A to be able to help Dr. Pusong and I not to forget the questions. So may I now call on our next reactor, which is of course the head of PBS, Dr. Orlando Ocampo.
Thank you, Jeff. I don't have any slides to share for this reaction. Let me start by thanking the Committee on Surgical Training for initiating symposium of this magnitude as a venue for dialogue concerning training issues. First, let me thank my friend Dr. Deo Reyes and the PSGS for spearheading ingenious projects attuned to our needs during the pandemic and beyond. The first issue that they discussed regarding the hybrid online learning system was sufficiently discussed by Dr. Rosario. Suffice it to say, in line with that, I heard that the PCS is embarking on I think purchasing an online platform of that sort. I think it's Moodle, that's what I heard. And I think that would help us provide our own LMS and of course, maybe also provide us with an online exam. So let me just react on DEO's rolling out of the residents' learning instructional portfolio for our surgical trainees. It's nice to know because I heard DEO talking about that several years ago. And I'm happy that the PSGS start to roll this out. And from what I heard from DEO years ago, this would be this would provide a structure for our resident to develop their individual portfolio of cases and experiences. And this would be a good vehicle for reflective practice, which is essential component of professional development. I won't touch on what Dr. Solomon is discussing because I know that would be the meat of the matter, and I am sure most of the questions will be geared towards that later. But with your indulgence, I would like to update you on what's happening to the Philippine Board of Surgery. So as you all know, we didn't conduct any examinations last year. So this year, we are planning to conduct 2 written diplomate exams, 2 RIT exams, and maybe 4 or maybe 5 oral exams. Well, we are fortunate to conduct half of those tasks so far. We conducted 1 written diplomate exam last March, followed by RITE last June. And then before the June ends, we conducted our first oral exam after postponing it twice because of the surge. And hopefully, ang problema ngayon yung flooding. Hopefully, we can conduct the second oral exam for tomorrow. Okay. So for the rest of the year, we are planning to conduct our second written exam this September. This will be followed by RITE on November. And hopefully we can squeeze in 2 or 3 oral exams in between. Let me take this opportunity as well to thank the PBS Board of Directors, Board of Governors, and the examiners for their unwavering support. And despite the odds. Kaya natin ito. Thank you very much.
Thank you, Bo. So now may I call on our reactor coming from the residents group, Dr. Corina Garcia.
Hello, doctors. Good evening. So today I'll be, again, sorry, thank you for PCS for inviting me to react and share my experience as a general surgery resident during this pandemic. So next slide, please. So these are the challenges as mentioned by the other training program as well. We have decreased number of cases, skeletal duties, covert ward duties, which ends with decreased surgical exposure. Next slide, please. And again, other problems as delayed diagnosis, which is a problem for both the patient and the resident. And again, which is somehow left out, is a topic of anxiety, depression, and fatigue. So next slide. So how did we adapt? So because of this pandemic, Zoom webinar became the new normal. So what are the pros and cons for us residents? Now we can attend international conferences, and we are currently updated to the latest surgical management. So we are at par with other residents abroad and also here in the Philippines. But what some people have overlooked are the consequences of it. So some webinars are conflict with our in-hospital trainings or in-hospital conference or another webinar. And we've been on Zoom conferences, webinar for more than a year now, and I believe it's true for us, for the consultant as well, that Zoom fatigue has happened. Next slide, please. So as mentioned by Dr. Leo, we also have hybrid training. So for the first year and second year, we have suturing. The third year and the fourth year have bowel anastomosis training. And for the fourth year, the fifth year, we have MIS training. These are all useful and to augment the training that we are lacking. And to be fair, these trainings are almost close to one-to-one. So even we can the consultant can tell us or teach us what are we doing wrong or what are we doing right during these trainings. Next slide, please. MCGA, please. So as mentioned, we are one of the hospital who were visited for the virtual accreditation, and I must say that preparation for this is as tedious as the physical one. But I would like to thank the PSGS for their leniency for this. And also, as mentioned before, they have allowed outside rotations and surgical missions, which made us, the residents, flexible with the training without sacrificing the surgical skills that we should be gathering or doing during this pandemic. Again, as we were very thankful to get the 5-year accreditation due to the rubric and the PSGS. Well, it was technical difficulties did happen, but they were very patient in helping us during this this time. And also, as mentioned, we have CERES and RITE. So for the CERES, we had online exams. So what were the thoughts of the residents during this time? So before the exam, we were thinking of studying. So how will this thing go, the online exam? During the exam, we were worried or anxious, will we be disconnected? Will our exam be accredited? And truth of the matter is, after the exam, topics arise such as, was really cheating a part of, or did it really happen? As for the face-to-face RIT, what are the consequences or what are the anxiety that, or what we were thinking as residents were a small sneeze or a cough that we heard. Some residents were very anxious, will I be exposed during this exam? So again, both the online and the face-to-face are a success, and I believe both needed by the surgery not to gauge our learning if it is at par with other surgery residents in the country. So that is just my reaction. Thank you.
Thank you very much, Dr. Garcia. Just to remind everyone, please type in your questions in the Q&A, and we'll take note of that later. Dr. J.
Yes, thank you, Dr. Jeff. Thank you, PSGS, for sharing your insights. I know a lot of residents are waiting to hear from you. Moving on, let me now call on the last set of speaker and reactor from the Philippine Society of Pediatric Surgery. For our first speaker, we'd like to call on the Secretary of the Philippine Society of Pediatric Surgeons, Dr. Jose Modesto Abeleria III. Dr. Abeleria, sir.
So, good evening, everyone. Allow me to share my screen. Can you hear me?
Yes, sir. Loud and clear.
So, I'd like to thank the PCS Committee on Surgical Training for this opportunity. We'll try to make this short. There are already a lot of questions for the for the general surgeon. So anyway, I have no disclosures. I am presenting as the chair of the Committee on Training of the PSPS, as well as previous chair of the board last year. So just as an introduction, PSPS is actually 50 years old already. We celebrated our 50th anniversary last 2019, and we had this magnificent ball, and we really had fun. However, the pandemic came in the early part of 2020. And as you all know, during the early part of the pandemic, we lost our immediate past president, who was also the chairman of one of the training programs that time at the PCMC. So it was a really a very difficult time for the society. So early in the pandemic, we instituted the Dr. June Resurrection webinar series to honor our fallen colleague. And in this endeavor, we actually had our tech support or actually the fellow. So very early in the pandemic, they really were already becoming more adept in conducting and coming up with these webinars and using Zoom, etc. So also during early in the pandemic, we did a survey of the programs early on, and there really was a decline, a significant decline in, I was the one who surveyed the training institutions at that time during the first month, and then the second month immediately after, and numbers were really down. However, during early in the pandemic, Zoom conferences were instituted quite early. And in these Zoom conferences, all the fellows attended, all the different trainees attended the different conferences of the other training programs. So in a way, with the lack of cases, the cognitive learning was not too far behind, because we were able, the fellows or the trainees were able to see the other cases that were being done in the different programs. So early on, we also had, we came out with our COVID guidelines, and this was published in PJSS, and we use this as a guide in the different training programs also. So what are the challenges? Basically, we had a problem because there were 2 new training programs in 2020, Jose Reyes and Vicente Soto, in addition to the 4 existing, which was PGH, PCMC, National Children's Hospital, and Southern Philippines Medical Center. As everybody knows, PGH and SPMC actually became COVID referral centers. So there was really quite some difficulty with regards to cases as well as training in those institutions. As everybody, all the training programs had very low number of cases. They also had problems with the patients not being admitted or not being accommodated and had to go hospital hopping. And of course, parents were afraid to bring their children. And early on, the effect of COVID in children was not generally well established or not clear. Okay, so there are a lot of asymptomatic COVID cases also. So since we do not have a trainee organization, I did a survey of our trainees, and so that we can present it also. And well, fortunately, all of them answered, and this is the breakdown. So, well, in terms of their perspective, well, fortunately, all of them are already vaccinated completely, and either Sinovac or Astra. as the like the experience of other trainees in the different other programs, they contacted COVID also at least once during the training or during this pandemic. And they were also quarantined due to exposure risk up to as high as more than 3 times, 3 to 4 times. Only 15% or only a few were never quarantined. And of course, in the COVID referral centers, some were asked to volunteer or were required to take care of non-surgical COVID patients in a ward or ICU setting. So, contrary to the idea of a lot of time, most of them were not able to finish their research requirement during the pandemic. And based on the trainees' perspective, an average of 50% reduction in operative and case indexes were experienced by their programs. Okay, so this is actually borne out by the 2020 census that they submitted early on this year. So more than half of them were not able to meet the case requirements during the supposed period of their training, such that a lot of them were extended. So as you can see, a majority of them were extended from 1 to 3 months to at least 1 to 3 months to more than to at most a 1-year extension. So in the survey, they expressed a lot of concerns, basically 2 themes. Of course, uncertainty, unpredictability, and anxiety regarding the index requirements and their training. So including the extension. They feared that there was not much patient interaction, there was limited exposure to MIS cases, and because of the lack of cases and the lack of opportunity to do surgeries, there's a lack of confidence in being able to do especially difficult ones. Of course, the other theme among their concerns was related to COVID, the safety, they miss their families, their children. Of course, in relation to the COVID, the institutional limitations. And this is what affects them emotionally and mentally. Okay. And of course, as has been mentioned, there's Zoom or online fatigue. So when asked how confident they were in practicing as pediatric surgeons once they graduate, then nobody answered they are confident or are very confident. So what were the solutions employed by the different training programs? Again, similar to the other presenters for the past 3 webinars. Of course, there were virtual conferences, not only within the department, but inter-hospital, national and international conferences. Some have online quizzes. In one institution where they had the facility, they did simulations. Or, of course, everybody was doing telemedicine. Some institutions had MOAs with other hospitals so that they can operate there. And of course, pay assists, not only in the institution, within the institution, but also at other hospitals. Staggered duty schedule was employed, and scheduled leaves as well as wellness breaks were also employed by some training programs. So in 2020, early on in the pandemic, at around June 1, the board came out with a memo giving 0.3 points for first assist in both service and private cases, and encouraged the programs to come up with MOAs with other institutions. And extensions were allowed and the programs were given the autonomy to decide for themselves whether they need to extend their trainees. So the diplomate exams and the residency in service exams during the 2020 year were canceled, and the revised the technical skills evaluation guidelines were revised. So since 2016, the board already eliminated or did not do the practical exam anymore. Instead, the board went to the institutions during their last quarter of training to evaluate their technical skills, and these were revised to include the remote format as well as video evaluation. So in the PSPS, we usually hold 3 inter-hospital conferences every year, and this was continued, but in an online format. Of course, we participated in PCS activities. As has been mentioned, due to the COVID pandemic and the ease of doing online conferences, a lot of the trainees were able, and the fellows were able to attend international conference because these were free or at very reduced rates. And the PSPS, owing to the pandemic and extended the accreditations of the training programs that needed to be reaccredited or revisited. And these subsequently were done via virtual accreditation visits. So just an example of the different international conferences that the trainees were able to attend. Alberto Peña was the pioneer of the PSARP, and he did this course for free. And of course, we were able to attend the American Pediatric Surgical Association annual convention at a very reduced rate of $20. So these are just some pictures of the virtual accreditation of Jose Reyes and of Vicente Soto during the early part of the second quarter. And these are pictures of the inter-hospital conferences that were done virtually during this pandemic. This was for this year. So on re-evaluation of the continuing pandemic, the PSPS and the board changed the value of 0.3 to 0.5 for first assist and for pay assist. MOAs with other hospitals are still highly encouraged. And again, the graduation or the extension is still dependent on the institution or program. We have already conducted or resumed the written diplomate exam this year. And unlike in previous years where it was done in Manila, this was done in 3 sites, Davao, Manila, and Baguio. And they were all interconnected via Zoom so that the other sites can see what was happening in the other sites. And a virtual technical skills evaluation and virtual orals are already planned, as well as the RITE. So the board is back to its job of certifying pediatric surgical graduates. The PSPS and the PBS came up with an ad hoc committee on the revision of index requirements, and this is due, long overdue, and to look not just on the pandemic, the effect of the pandemic, but also looking forward into the future. And a curricular revisit is also being planned by the society. So just a picture of the written certifying exams. This was in PCMC. And also a virtual technical skills evaluation scheduled. This was the dry run, and it is scheduled for next week, again for graduates of PCMC. So basically that's it. However, just like to note that again, during this year, we were hit with another unfortunate occurrence. Our past president and the chair of the SPMC training program unfortunately passed away. And again, this was another hard hit to the society as well as to the training programs involved. But however, we are still hopeful. We are still doing our jobs, and we are still taking care of Filipino children. And basically, I'd like to thank our trainees for answering the survey. Thank you to everyone for your kind attention. And these are our online presence. And good evening to all. Thank you.
Good evening, sir, and thank you for your share. I would like to condole with the society for losing two of their fellows. So to react to Dr. Valeria, we would like to call on the chairman of the Philippine Board of Pediatric Surgery, Dr. Bayani B. Texon. Dr. Texon, sir.
Okay, allow me to just share my screen. There. Okay. There.
Okay. It's yeah.
Sorry for that. It's not ready-made, so it's just oh. How come it's not God. There. We'll just put it there. So that is it clear now, or it's not clear?
It's not centered, sir.
Oh, okay, so we'll just stop share for a while, and then we'll just start screening again, and we'll just go basic. Okay. Is this okay?
Yes, sir. You just have to go to your slide presentation. Just have to play it. Okay,
There.
sir. That's fine. That's fine, sir.
Okay. Okay. So sorry for that a little technical glitch, and thank you for the PCS Committee on Surgical Training for this invite and allowing us to share our own experiences and at the same time perspective on these challenges and innovations that we have done in pediatric surgery. And to Dr. Abellera, thank you very much for that comprehensive talk on what we have done in pediatric surgery, in coping up with the challenges, and at the same time how we got through all this. So we all knew about the challenges that we underwent, and it was already emphasized by all the training programs, including Dr. Abellera just a while ago. So no need to go into that. And again, to put emphasis on the scare of our life that happened in the pediatric surgery family. We are very close-knit association or society. We are even less than 70 fellows in the society. So what happens to one is it will be felt by everyone in the society. And our response to this event and the demise of Dr. Resurrection has been an emotional one. So early on, we educated ourselves more on this pandemic. We went overly cautious and practiced defensive medicine. Even with those measures, some of us, as you have seen, more than 50% of our fellows in training had contracted the COVID-19. And many of us also practically got quarantined several times over because of exposure. We had our individual responses. We participated actively in our institution's COVID-19 management committees. We attended COVID-19 webinars to educate ourselves. We attended workshops. Most of them are free, but sometimes we paid just to give us more education on this COVID-19 and how to battle it. We became policy-making bodies of our hospitals and became scientific resource persons in the communities, even into the cities that we live in. Our personal protective equipments has been personal purchases. And at the same time, of course, some lucky ones had benefited from donations. But in the provinces, most of the time, we just purchase our personal equipments. The training programs had their own responses and making sure that our trainees were not left behind in our priorities. Several adjustments on workloads and duty schedules were made. Index cases completion were closely monitored to the point of really going into individual performance of every trainee. MOAs were forged with other institutions, which were very difficult to do pre-pandemic, now became easy. We had the cognitive learning actually never was shortchanged because learning continued with webinars, allowing us to attend local, regional, and even international conferences. We have been flexible in the duration of our extensions of our training, just so that we can show some compassion to our trainees. Other than the individual and institutional or training program adjustments or responses, the whole society, the Philippine Society of Pediatric Surgery and the board, the Philippine Board of Pediatric Surgery, really worked closely and collaborated for more than ever, so that our PSPS Council, our Committee on Surgical Training, and the Committee on Surgical Training Program Accreditation really work hand in hand. We went on to revisit a pediatric surgery training curriculum and really look into, that's the only way we can implement good training and make sure that our trainees will get the training they deserve and they need to become independent surgeons. We went on to revisit our index cases requirements, and in that we are now in the process of actually looking into organ case or organ system case mix formula, wherein we don't require any more certain number of cases to be done, but on the organ system itself, like for example, colon and rectal surgeries in children. Instead of saying you have to perform 25 appendectomies, 10 of this, if you have a good case mix of operations and cases on the colorectal field, then that should be enough to qualify you to board eligibility. Having worked early on in this, we came into a common principle, working principle, that there should be no compromise on proficiency. So even with those adjustments in the training processes, even with those graduation requirements modifications, eligibility processes remain. Meaning they still have to go for the individual screening of their cases, index cases performed, their research requirements, their passing the written, the oral, and the technical skills evaluation will have to be performed. We have to make sure, and we all agree, that our graduates that we certify should be proficient pediatric surgeons. Obviously, just like other training programs in other specialties, we did not also conduct our certifying examinations in training examinations and technical skills evaluation in 2020. But in 2021, this year, we had a new board and we came up with some hybrid format in conducting examinations. We went on, because there are only few examinees for each time. We, after benchmarking with the shared experiences of other specialties, particularly general surgery, we decided to have face-to-face examinations with Zoom monitoring. And we conducted this first written certifying examination this year on multiple sites to again distribute the number of examinees. Before, it's only conducted in Manila. The technical skills evaluation prior to graduation has been planned to be done. Actually, we just had a dry run 2 days ago, and it's working on well. So we're scheduled to have this technical skills evaluation on a hybrid format, face-to-face with Zoom monitoring next week. And the certifying oral examinations will also be resumed with this format. Now, what's the outcome of all this? When we have these challenges, in times of adversity, we evolve and we modify ourselves, and we come up victorious. And I believe that is resilience in every one of us, particularly our trainees. And I salute all the trainees who did not resign during this time of trouble. The first certifying written examination in June. Remember, mind you, the certifying examination that we conducted were taken by first timers, those second time takers, and even there are even examinees that took it this year for the third time. And this is a testament that whatever the societies are doing, particularly pediatric surgery, the innovations that you have done, that were implemented, inspired these trainees, and actually all of them passed. Now, there was a question initially whether did we recycle board questions, and the answer was no. We are new batch of board members in the Philippine Board of Surgery. Did we make easy questions? Definitely no, because each question underwent MPL determination and item analysis. It's the same scrutiny as just before. And so this is a testament that whatever we have done for the training of our junior or younger colleagues to become specialists of the future, the doctors of our children and grandchildren. It worked. And I congratulate everyone in the PSGS, in the colorectal surgery, and of course in our society, pediatric surgery. Your resilience has come out to be fruitful, and we are victorious in every way in this pandemic. Thank you very much. That's all.
Dr. Jeff, that was a PSPS for you.
Well, thank you, the PSPS. We learned a lot from your society. Now that we've heard everyone, can we call on all the panelists and the some of you who would want to participate in this virtual floor to the podium so we can start answering the questions? Dr. Pusung and I will actually try to read all the questions that were fielded in the Zoom chat and of course the Q&A. With trying to limit it with the limited time that we actually have right now. So Jay, can you start with the first one that you can read?
Yes, sir. I'm looking at the chat box. I think we can answer the question of Dr. Rex Madrigal. It is addressed to Dr. Solomon. Sir, absolute pa din yung must pass junior and senior level RIT and CERES to be eligible?
That requirement will be in effect. Sandali nga, may dumating na food panda anyway. Hindi, may nagpadala sa akin, hindi man bayad, anak ng wet.
Sa amin galing yan, sir.
Ewan ko, dali. That requirement will be in effect 2022. Okay? Right. Yung you have to have passed kaya first year ng 2017. Okay? Because that was incorporated sa manual ng 2017. So ang effect niya is 2022 for next year yan. Yung sa RIT naman, I think they will get 80%, 20% of the top 4 scores sa RIT will be considered, and 80% sa part 1. Yung sa CERES, at least napas mo yung basic and napas mo rin ang clinical. Okay?
Okay. Thank you, sir.
2022.
Thank you. So that's it for 2022.
I think there's a good question here, Dr. J, galing from Dr. Martinez.
Yes.
Was
yes,
talking
sir.
about the categories, right? Is still counting the number of cases and how to complete the number of cases in our curriculum or teaching strategies. Actually, outcome-based learning, diba? So
yeah.
is this
yes.
The question is this the correct assessment? Or shouldn't it be competency-based?
The numbers is only part. The numbers is only part. If you look at your rubrics, the rubrics scoring system for accreditation, it's a 6-part. And the numbers is only part of that. Andyan yung administrative support, psychomotor, mortality, morbidity, which will be an assessment of the outcome. Board passing, passing in the CERES in the right. The number is only a part of that. Hindi man tayo, pero sabi ko nga kanina the 170 as of last year, sabi natin with the PBS stays. Okay yan. Gawan na lang natin ng paraan kung paano natin ma-satisfy. The 100 also by the PBS stays, and I think we have been quite lenient. We were reactive last year because hindi natin alam yung tumama sa atin Okay. Yeah. So it's in the pipeline. The committee, kung kami pa rin ng committee after August, we'll be having a seminar if we will revise or tweak the manual or major revision in response to, sabi nga ni, I saw Robertson's comment, we were reactive. Yes, everybody was reactive last year. Then we have to think about, okay, paano natin, COVID or not, we have to have siguro major revision of the manual. Okay. Did I answer the question?
Yeah.
Dr. Jeff, there's a question from one of our committee members, Dr. Janix. I think this can also be answered by anyone from PSGS. So, sir,
Sige.
what happens now to the fifth-year resident who is allowed to graduate if he did not complete the deficiencies within 2 years? And the second question is, how about the training institutions?
Okay.
Will
Sige.
PSGS impose penalties to the resident only or to the institution as well?
No, we will not. We won't give penalty. Wala. Never in our wildest dream magbibigay kami ng penalty. So yung 2 years na yon, that was just a parang a tentative time para pero sabi ko nga kanina, hanggang kailan masasatisfy, wala tayong definite time na 2 taon.
I think kasi mahaba yung discussions na napunta doon sa chat box regarding outcome-based learning.
Yes.
But if we were listening to the talk of Dr. Warren Ruraldo earlier on, di ba sinasabi niya, we should define the objectives right at the start. And then, we now make assessments depending on the outcomes that we want for our residents. And I think that's a very good discussion made by Deo, wherein he was already, in the mind map, which I always amazes me, di ba? Very logical yung thinking. Ano dapat yung objective? Ano yung gagawin nating assessment? Ano yung outcome? So how do we assess these people? Any comments? Deo, maybe you'd like to say something, or maybe followed by Dr. Warren.
I didn't quite get the question, sir.
Hindi, yung sa outcome-based learning kasi.
Outcomes-based. Right.
A lot of us kasi are based on the numbers of our cases. So, di ba, how do we define the outcome? Is it the number that is important to us to define a skill that we want to develop? Di ba?
I think that question has to be taken in 2 different concerns. The first one is in the case of curriculum design, and the second will be in the case of accreditation and eligibility.
Okay.
And as far as our curriculum is concerned, the outcomes have been aligned with the teaching learning tools and the assessment. I think the question really more is a matter of accreditation because of the changing times. And I think, personally, simulation will play a role. There was a question in the chat box, and as far as time lost is concerned, lost operative experience, and so on. I think we will be learning more to implement simulation to play a role to address these gaps. Probably, aside from learning, we will still have to develop our competencies and structures to be able to implement simulation in that way. But I feel that in the future, pandemic or no pandemic, simulations will really have to play a role, and that could be possibly one of the ways to address these gaps.
Skill-wise, yeah. Thanks,
Yes,
Deo.
skills-wise, yes.
Dr. Warren, any comment to that?
Yeah, I agree with Deo. Siyempre, the written curriculum is there already. And as it was written, it was aligned. Again, yung accreditation, sabi niya nga, should be aligned doon sa what is written in the curriculum. Siguro ganun po natin titingnan upon adjustment. Talking about outcomes, when you talk about outcomes, this does not ask na about timing, numbers, hindi na po yan. Basta fulfillment of the outcome. Yun na po.
Thank you. Thank you, Dr. Warren. Jay, meron ka pang nakikita dyan?
Yes, sir. There is one again from Dr. Madrigal. I think this is with regards to the extension of the resident. So government policies on item allocation. So how can we help the residents who will be extended? So if you will extend, baka wala na siyang item for, like Dr. Texon said,
yeah,
extend ng mga 2-3 months, wala na siyang item nun. So anyone who wants to answer that?
May mga institutions na nag-extend talaga with salary, but hindi ka mag-appoint ng bagong first year. Okay, so in the long run, hindi lugi hospital, walang dagdag na gastos, in-extend mo lang. But actually, it's ang isip ko dyan is, it is the training program, ha? The program director, the training officer, siya magde-decide if pwede nang pakawalan tong residenteng to, tong graduate na to, even if kulang ng kaso and sa labas niya na lang kunin. It's up to them, it's up to him. Ha? Siya ang makaka-assess eh. O sabihin mo na-meet niya yung 10 thyroids na minimum, o pero ang feeling niya ay kulang pa, he's the one. He can graduate but he cannot issue an eligibility for that resident. Ganun lang naman. It's we are in uncharted times. Talagang medyo mahirap talaga.
So ang napansin ko, among all the training programs, we sort of adjusted and accredited yung mga cases done outside, diba? As mentioned by Dr. Crisostomo, yung cooperasyon, diba? I think that was a very nice term. And kasi dati ang basihan natin of accreditation of a training program was the institution and the number of cases in the institution. Now it's more like, the resident is himself as an individual, or the trainee himself as an individual, meeting the outcomes that you have determined. And I think that's very common in all the programs that the comments that you actually presented. What's also very nice, I think, is what the colorectal surgeons did. Almost all of them actually participate in a unified conference. So maraming sharing of ideas. And for the GS programs, medyo maraming too many audience siguro. But I think that's a very nice idea that's being done.
Dr. Jeff, with your indulgence, can I ask Dr. Texon?
Yeah, yes, please.
Yes, Dr. Texon, can you elaborate on the organ system based on the accrediting your required number of cases? If I would like to ask, para bang pag gumawa ka ng colorectal at nag-gallbladder ka 1.4 gallbladder and 1.4 colorectal, colon? Ganun?
Ay, hindi po ganun. Because what we had before is basically, we specify the number of appendectomies, 25. Number of colon resection, 15. Number of Hirschsprung's pull-through, 10. Instead of that, we satisfy a case mix of colorectal surgery in children, 30. Doesn't matter if that will be 10 appendectomies, 20 Hirschsprungs, it's in general. Because proficiency in colorectal surgery will be on a system, on organ or system based proficiency, not just on skill in doing appendectomy. Diba? So yun po yung pinag-iisipan na ngayon, case mix. Enough case mix for a certain organ. For example, gallbladder. How many gallbladder surgeries would you require for a pediatric surgeon to say proficient to do biliary surgery? We have 10 gallbladder surgery, 10 choledochal cysts, and 5 liver resections. Instead of putting in the 5, 10, 10, let's say how of the hepatobiliary organ in children, how many have you done? Is it enough to call it proficient in doing choledochal cyst, gallbladder? Because doing choledochal cyst, eventually you will, inadvertently you'll be doing cholecystectomy because it's part of the procedure. So basically, instead of just numbering or getting into the number, we're looking at the organ, how many surgeries in this organ will it make you proficient? For example, because in pediatric surgery, basically a general surgery as a whole. So it's not just the same as colorectal, where you have benign colorectal diseases, oncologic colorectal diseases, and rectum and anus diseases. They only have 3 panels. We usually have 8 panels in surgery because it is a holistic surgical treatment in children, or holistic approach to children's surgical condition. So we have head and neck, we have respiratory diseases, we have colorectal, we have soft tissue and tumors. So it's an 8-panel examination during the oral exams, and also even in the written exam, we get the same number of questions for each of these organ systems. So that's what we're looking at now in the board and in the Pediatric Surgery Society.
Thank you, Dr.
Outcome based. We should look into the outcome. Will they be proficient when they go out and practice the craft in the provinces on their own?
Thank you, Dr. Texon. Just unlike in PSGS, sir, in PSGS under hepatobiliary, there are index cases that you should have performed. Hindi by system. So will that be helpful, Dr. Deo, if like for example, if you do it multi-system surgery, you can count one each for that as a fulfillment of a case requirement? Can you comment on that?
That's a very difficult question to answer.
Sagutin ko na lang. Parang gustong manggulang nung residente anyway.
It depends on what case comes in.
It depends on what case, ano ang index case talaga na ginawa mo. Kung ilalagay mo diyan lahat yan may additional-lysis, ilagay mo lahat ng additional-lysis. Tapos maglolokohan lang tayo, no. It's the primary surgery na ano ba talaga ang primary surgery nitong taong to. That's it. Even sa hepatobiliary, hindi naman cholecystectomy, nakahiwalay yung CBDE. No. It's totality of the procedure.
Yes. So kung ano yung sinabit mo sa PhilHealth, sir?
Ayun.
Dapat totoo.
Okay. Doc Jeff?
And then may comment, I think very nice comment ni Dr. Gabby Martinez. He was talking about proficiency is outcome-based. One may have performed a minimum number of cases with high morbidity and mortality. So is adequate numbers equal to proficiency? That's a very good point, di ba?
Yeah. Kaya actually in our curriculum, it's again it's a two-faced deal. It's a matter of curriculum design, and then it's a matter of accreditation. In as far as learning is concerned, of course, the numbers do not follow. I guess it's a compromise that has to be made in as far as accreditation is concerned. Not until we are able to come up with other metrics that will work both for curriculum and accreditation. I guess it really is not equivalent, but at this time, probably it's the best compromise that we can come up with for now. I don't know about Dr. Solomon.
Yeah, may nakita kong question kanina yung with regards, nakalimutan ko na.
Food Panda yan, sir.
Hindi. Hindi pa dumadating. Anyway, later na lang. Yung iba na...
Dr. Solomon, I think it's the program factor. I saw it.
Yeah. It's the program factor. Kung bakit daw for... I think we discussed this before. Okay.
Yung resident factor, bakit
resident factor, kung ba ito ang proficiency, include ba lahat? For example, you have a 5 residents, so that's a factor of 1. Tama? 5 divided by 5. So, may nag-question kanina na, hindi ba yung first year and second year, ihiwalay mo individual first year and then second, third year, fourth and fifth, hiwalay mo yung mga competencies nila. That's kung gano'n ang pagkaintindi ko, Bok, anong mo diyan?
Let me siguro take this opportunity. Medyo opportunist ako ngayon eh. Take opportunity. Meron kaming ginawang study which will be presented in the PSGS convention.
Yan, oo nga, yes.
Typically tackling that particular issue. Bakit kasi i-multiply nyo yung kole, yung first year di naman nagko-kole.
Yeah, yeah.
But number of, the residents who really performed the operation, and sila yung ginamit naming multiplier para doon sa number of cases. So you will see. Iba yung ano eh. Anyway, again, siguro para ma-invite ko kayo. So it's in I don't want to reveal it eh.
Reveal na.
Videos kasi ang magpipresent yan. But that's our paper. That's a 10-year study actually that would analyze ano ba yung dapat. Kasi ang nangyari kasi Dr. Solomon, I'm not blaming anybody for this. Parang naisip natin, sige 10 na nga yung kole, yung breast 10 na rin. Pero hindi natin alam saan binunot yung number na yon. But in this study, you will see specifically ilan yung ginagawang kaso, ilang residente gumagawa. Ilan ba talaga dapat yung number na yon? Instead of just, parang pinunot mo sa hangin, nilagay mo doon dahil yun ang gusto mo. Pag bumaba yung ibang program, you keep on adjusting it. Ito yung sinasabi ni Dr. Robert So eh. Pag dugtong-dugtungin ko na, nababasa ko kasi chat eh. Maybe we need to fix this once and for all. And I think this study can help you or guide you on how to fix the number. Okay? Yun lang. Medyo bitin, pero...
Yeah, oo. May I butt in? Yeah. It concerned na talaga yan even so many years ago. If I remember right, sa PCS pa yan nag-workshop kami na saan natin nakuha tong numerong to? Saan natin na bakit parang different training programs o ito 10 ang kailangan. Ilan nagagawa mo? Para turuan lang ikaw, ilan na nagagawa mo. So talaga walang scientific basis. And at least yung 170 na requirement ngayon per 5 residents sa accreditation, medyo napag-isipan yan. From a previous of 200 yan, 100 major and 100 medium. Pero kulang pa rin talaga. Magagawa, bakit kasama yung sa factory, first year sa APR, bakit kasama, di ba, ganun eh. So it should be individualized and it's gonna be hard, pero I think it's the right thing to do. Medyo mahirapan talaga as far as sa accreditation committee, surgical training, mahirapan pero it has to be done.
It's a very well said, Dr. Solomon. And marami nga tayong kukuhang bagong ideas now and how we can rethink our training programs. In fact, yung sa pediatric surgery na system-based, parang okay to. Ibang idea naman to. But as we go back to where we started in the talk, what is your objective? And now you make an assessment of that. So yung outcome-based learning na yon is siguro yung end point na how do we want our trainees to be when they graduate should be well-defined. And then we backtrack, di ba? And make these programs for these people. Jay, meron pa bang mga question? Baka hindi pa natin na discuss.
I think, sir, we have none. But the study of Dr. Bok is one reason to attend the forum.
Oh, definitely. Yeah.
Plug.
So, kailan po yun para makalendar na?
Okay, sir. I think there's no more question to address.
Okay, so for the interest of time, I think we've learned a lot for tonight. We started off with training and the background given to us by Dr. Oraldo and the value of how we should all learn how to use technology now. Diba? So, our learnings may be different depending on your age. So how we can adapt to the science of the times. And it's very nice that we heard a lot from the different speakers and reactors from the from the colorectal surgeons, of course, GS, and of course in pediatric surgery. So unfortunately, because of this pandemic, we actually were hit and our training programs were severely compromised. But I guess there are pearls that we have learned from this experience that we will apply in the future. And Deo was already alluding to that. And I'm sure it will make us even better trainers and even better surgeons, di ba? So again, I like what Dr. Crisostomo said, cooperation, you know. So this is not a competition between all of us. This is how do we make better surgeons in the future. So we have to be flexible, creative, focus on outcomes. I guess it's very nice. So we have to work as a team. So indeed, we would like to thank the members of the audience who stayed on with us. Especially, of course, I'd like to thank, of course, our chairman, Dr. J, who did a good job following the questions. There's a lot of provoking questions, di ba, Jay?
Yes, sir.
So, and to our generous guests and speakers, thank you very much. To the reactors, we have learned a lot from you. So to the members of the PCS, CST, and of course, headed by Dr. Pusong and of course, the telemedicine network, thank you very much. So having said all of this, Jade, do you have any more last comments before I pass the floor to our boss?
From the PCS Committee on Surgical Training, sir, being the chairman, I would like to thank all the speakers, the reactors, the members of the CST, and all the participants for attending the 3 webinars. We have a good attendance for the 3 webinars. Thank you, sir.
I think we have achieved our goals, and thank you for this opportunity and giving us this opportunity to share our ideas. So to wrap up this activity with these closing remarks, it is now my pleasure to call upon the Regent in charge of the PCS Committee on Surgical Training, our energetic boss. The virtual floor is yours, Dr. Albert Paulino.
Yeah, good evening. Thank you, Jeff. The word of the day is collaboration and cooperation. And I think we should be starting doing that, okay? So having said that, my congratulations and appreciation to this afternoon guest lecturer, our speakers from the different subspecialties, and moderators from the different boards, specialty boards, as well as the residents and fellows who took time out to attend this series of webinars. I ardently hope that you were able to get some pointers on how to mitigate the impact of this COVID pandemic in your respective surgical training. And of course, I would like to thank 3 hours tayo ngayon kasi nandiyan ang PSGS eh. Nandiyan si Dr. Solomon. So, thank you for Dr. Jeff Domino of TNP for allowing us to use this very reliable and wonderful platform. So with that, again, thank you everybody and good evening to all of you. Mabuhay tayo sa PCS.
Stay safe.
Good evening, sir. Good evening to all.
Thank you, everyone.
Thank you, Joe. Thank you. As a short notice, Joe. Thank you.
Thank you. 2 days.
Solomon, sir.